Good evening and welcome. I know some are still joining in with us. We'll give them a minute or two, but good evening and welcome to the Rogosin Institute's presentation on IgA nephropathy, empowering the patient, caregiver, care partner with knowledge. My name is Christina Bishop-Feeney, and I am the Director of Development and Public Affairs for the Rogosin Institute. As you know, a national leader in the diagnosis, management, and treatment of kidney disease. I would like to thank you for joining us for tonight's event. We have over 200 registered with us, and I know folks are going to be filtering in as we get underway here. And I just wanted to thank you and let you know how much we appreciate your time and interest in Rogosin's educational presentation. It is also my great pleasure to introduce our speaker tonight, Dr. James Chevalier. Dr. Chevalier is director of the Jack J. Dreyfus Kidney Clinic on Rogosin Institute's Eastside campus. He is assistant professor of medicine and medicine and surgery at Weill Cornell Medicine, and an assistant attending physician at NewYork-Presbyterian Hospital. Dr. Chevalier cares for hundreds of patients every year across all types and stages of kidney disease and coordinates comprehensive care, working closely with colleagues at NewYork-Presbyterian Hospital. Dr. Chevalier is a recognized specialist in IgA nephropathy and in polycystic kidney disease. And before I turn it over to Dr. Chevalier, I just wanted to go over a quick housekeeping item. Thank you all. I know you submitted questions when you registered. We have received all of those, and we're going to talk them through at the end, the ones that are relevant to our program. But we understand that you might have questions as Dr. Chevalier moves through the slides. So we would encourage you to place those in the chat, and Dr. Chevalier will address those as he moves along. And again, thank you everyone for joining us. And with that, Dr. Chevalier.
Thank you, Christina. And with that, why don't we go ahead and get started? So no better place to start than the introduction. I'll start with a quote in most of these sections, but I do think that one person told me one time that being told that you have kidney disease or IgA nephropathy can sometimes be a tidal wave of questions, fears, and emotion. So I hope that we explain everything well enough that it's no longer going to be confusing and overwhelming. I know that we have a lot of people with a lot of different levels of knowledge about IgA nephropathy, so we are going to talk about both the basics and some things that are more advanced. We're also going to have interactive questions and sessions, and hopefully you'll be able to talk and respond in the chat. So why don't we start at the beginning? It's called IgA nephropathy. So IgA stands for immunoglobulin A. That's one of several types of antibodies our body can make. And unfortunately, this antibody is made wrong by the body in someone who has IgA nephropathy. Now, those arrows point to the part that's wrong. You might have heard of something called undergalactosylated IgA, and that's what it means to be wrong. These squiggly parts should have a bunch of sugars on them. And the name of that sugar is called galactose. If there is not enough galactose on these squiggly parts, that means that it's undergalactosylated, and that means that this IgA is wrong. Now, you might also think of this top half as the picture of an antibody that you usually see. And to be fair, that is what an IgA antibody looks like when it's in the blood and traveling in our bloodstream. But IgA is the type of antibody that gets secreted into the lining of our respiratory tract and the lining of our GI tract. When it does, two of these IgA molecules get tied together, and that's how it gets secreted. So this picture over here is an anatomically correct IgA molecule, and it's what we'll be using for the rest of the talk tonight to explain or to represent a bad IgA. But let's get back to the definition. All right, so these abnormal IgA antibodies look wrong, and so they're attacked by the person's own immune system. The immune system antibodies and these abnormal IgA antibodies stick together. They stick together and make clumps that then get stuck in the microscopic kidney filters. Now, nephropathy just means damage in the kidneys. The damage in the kidneys is actually these clogged microscopic filters. And the damage to these microscopic kidney filters leads to symptoms that people have, leads to abnormal labs, and might eventually lead to permanent damage. So the IgA antibodies cause damage in the kidneys, and that's what we're going to talk about for the rest of tonight. Our first question, and we'll see if the chat really is working. True or false, IgA nephropathy is more common in men than women. So please go ahead and give your answer in the chat. All right, so the answer is true. It turns out that it is more common in men. Question number 2. A person with IgA nephropathy has about a 90% chance of a family member also having IgA nephropathy. True or false? The answer is false. Let's go through some facts and statistics. About 150,000 people in the US are estimated to have IgA, but many people don't get a kidney biopsy to confirm the diagnosis. Now, it was once called that guy's disease after the French doctor who identified it. We actually don't use names in the names of people's names in the names of diseases anymore, which is why it's now called IgA nephropathy. But it's very interesting because the pronunciation of that doctor's name is somewhat debated in the world of medicine. He's a French doctor, so a lot of people, myself included, thought it was pronounced Berger's disease. But others have pointed out that this is a German name and that it should be pronounced Burgers. Well, I think that both are correct. But once again, we no longer use that name because we don't put people's names in the name of diseases anymore. All right, one important fact, IgA is usually triggered by an infection, and the symptoms are usually at the same time as the infection. The reason that's important is that there are other autoimmune kidney diseases where a person gets an infection and then gets the symptoms several months later. What are those symptoms? Foamy urine from protein in the urine, blood in the urine to make the urine look red, pink, or tea-colored. Sometimes you don't even see the blood. It's just microscopic and is only seen on lab testing. Swelling of the ankles or other parts of the body, and high blood pressure. You may notice that 2 of those things are underlined. That's because blood in the urine and high blood pressure are the 2 most common symptoms seen by people with IgA, especially at the time of diagnosis. Now, anyone can get IgA, but it's most common in boys and men between the ages of 10 and 40, people of Asian, Pacific Island, or white European ancestry, people with a family history of IgA, but it's actually only about 10% of people. So speaking of blood in the urine, here we have 2 urine samples, one on the left and one on the right. One of these urine samples is from somebody with IgA who's having a flare-up of symptoms. Hopefully, you all identified it as the one on the left. Now, in a few more slides, we're going to talk a little bit more about how we analyze these urine samples. But to make it simple, when we look at the urine sample on the left under a microscope, we can see how many red blood cells there are. The sample on the left had so many red blood cells that it was too many to count. The sample on the right is normal. All right, so now we need to ask, just because we see a red-colored urine, is it blood or is it not blood? I mean, maybe somebody had a lot of beets for dinner the night before. Maybe somebody had a lot of red dye number 5, and that's why their urine looks red. Well, the way we check is we take a dipstick, a little piece of plastic that has a bunch of squares on it. This dipstick gets put into the person's urine, and all of the squares are covered in urine. We then hold it up to the guide here on the bottle. And on this particular one, which was that red urine we saw on the previous slide, we can see that there is a lot of blood in this urine sample. All right, what tells you the blood in the urine is from the kidneys and not from the bladder? Whenever you see blood in the urine, it could come from the kidneys, it could come from the bladder, it could come from the tubes that connect the kidney to the bladder, or it could come from the tube that has the urine coming from the bladder to outside the body. So how do we know that that blood we just saw on the previous slide is from the kidneys? Well, when the blood is from the kidneys, there's about 6 different hints. Protein in the urine goes along with blood in the urine from the kidneys. When we look under the microscope, which you're going to see in a couple slides, we might see abnormal red blood cell shapes. Red blood cells may clump together. White blood cells may clump together. The kidney function could be getting worse, or the high blood pressure could be getting worse. These 6 things sort of suggest that the blood in the urine that we see is coming from the kidneys. I do see a question about smoking triggering IgA. We're going to see in a little bit how most things that trigger IgA are things that stimulate the immune system. I'm not sure if there's a randomized controlled trial where smoking has been shown to trigger IgA, but I know it would contribute to worsening kidney disease. And I think that scientifically speaking, the mechanism of action would be possible. All right, so now another question that I get asked quite a bit. How do you tell the difference between foamy urine, which is a disease, and bubbles, which are normal? Well, let's look at this urine. So foam is thick, like the head of a beer, and you often can't see the bottom of the toilet. Foam also sticks to the side of the toilet when you flush, like soap suds. So in the cup on the left, you can't see the bottom because of all the foam. The cup on the right, you can see that the foam is about 1/3 to maybe 40% of the total height of the liquid in there because the foam is sticking to the side. Bubbles should pop and go away. And in this urine sample, I let it sit for like 15, 20 minutes, and the foam did not go away like bubbles usually would. Now, the only way to tell for sure is this protein or just bubbles is to get out our dipstick again. So as a reminder, this whole thing gets dipped. Every one of these squares gets dipped in the urine, and then we stick it up here against the guide. And this, once again, was that original red-colored urine that we saw previously. Now, this sample shows a ton of protein, once again, to go along with the blood in the urine. Now, this square up here is purple. Normal is white, but this is purple. I'll even tell you that this purple square is called leukocyte esterase, which means that there are white blood cells in the urine. Does that mean that this person has an infection? Of course not. But I think that even though white blood cells in the urine, the most common things we think of as an infection, there are other things that cause white blood cells in the urine besides an infection. Cancer could do it, allergies could do it, and in this case, it's inflammation from an autoimmune disease. There's been many a time that I've been referred a patient who I was told had recurrent bladder infections or recurrent UTIs, but never had a positive culture. And it was only because the other doctor saw lots of white blood cells, red blood cells, and protein in the urine. It turns out that a lot of the times they have an autoimmune kidney disease like IgA. All right, now this one's a little tougher, but basically what I did is I spun down the red urine and the normal urine from a few slides ago. One of the tubes is on the left and the other tube is on the right. It's a little hard to see, but down there on the bottom is a clump of blood and protein called the pellet. The sample on the left is from that red urine sample. The sample on the right is from the normal one. Let me explain. So what we do is we take this IgA nephropathy urine sample, we stick it into a centrifuge, and the force, the centrifugal force of spinning very fast in the centrifuge takes all of the blood and protein, which was sort of dissolved in this urine sample and brings it all the way down here into this little pellet of all the red blood cells and protein and makes the rest of this urine clear like the normal one. So this becomes this with the red blood cells and protein at the bottom. A sample is taken from the pellet to examine. We don't just take like an eyedropper and take a sample out of this. We sample this pellet, which is like a concentration of protein in blood. As we said before, if we see clumps of red or white blood cells or abnormally shaped red blood cells, that suggests that the blood in the urine is coming from the kidneys. Now, in the patient portal, you might see something reported as 25 red blood cells per HPF or 10 white blood cells per HPF. That HPF means high-powered field. It's just like the microscope that you're familiar with from high school. And when you put it on the high-power field, you can count how many red blood cells or white blood cells are seen in that high-powered field, and that's how it gets reported in the patient portal. Now, 5 or fewer red blood cells is considered normal. Many people with IgA nephropathy have more than 5 on the high-power field. And that, my friends, is the end of the introduction. The next thing we're going to talk about is the spectrum of IgA, meaning there's IgA and there's IgA. All right, so a lot of times when I tell someone, you have kidney disease, you have IgA, people get very worried. They ask me, am I going to die? Do I need dialysis? The good news is hopefully no. But I do want to talk a little bit about the spectrum of IgA. True or false? IgA nephropathy is one of the most common causes of kidney failure in the world. All right, so the answer is true. Next question. At some point in their life, every person living with IgA will eventually get kidney failure and either need dialysis or transplant to replace their kidneys. True or false? I see that this one's almost unanimous. And you are all correct. The answer is false. All right, true or false? When a person living with IgA gets a kidney transplant, they will never make abnormal IgA antibodies again. True or false? Once again, it looks like it's pretty much almost unanimous, and the correct answer is false. So let's talk a little bit about how IgA can be mild, aggressive, or anything in between. So some people are very lucky. They have one episode of microscopic blood in the urine that never comes back. But some people have IgA nephropathy that leads to kidney failure, and they do need to replace their original kidneys with dialysis or transplant. Because IgA is so common, and in the whole world, so many people have IgA, there's actually a large number of people that have IgA nephropathy as a cause of kidney failure. At one point, IgA nephropathy was the #1 most common cause of kidney failure before diabetes became a very common cause. We usually report about 1/3 of people with IgA nephropathy having kidney failure, but with modern treatments and earlier diagnosis and controlling risk factors, this is getting better. IgA antibodies can usually be found in a person's kidney transplant, but very, very rarely does the transplant fail because of the antibodies. It's good that most of the medicines that prevent rejection in someone with a kidney transplant also decrease the production of IgA antibodies. All right, but I have IgA in other parts of my body, not just the kidneys. So what is IgA vasculitis? So IgA antibodies travel through the blood all the time, just like everything else in our blood. And sometimes they can cause inflammation in small blood vessels in other parts of the body, like the joints, kidneys, GI tract, skin, etc. When we're talking later about damage to the small blood vessels in the kidneys, people with vasculitis can just sort of apply that to small blood vessels in other parts of the body. Now, this was previously called Henoch-Schönlein purpura. Once again, we no longer use people's names in diseases anymore, so it's now called IgA vasculitis. Once again, it's usually triggered by an infection. Symptoms is usually a rash, which is fairly distinguishable as being like something that you can touch and feel, usually purple dots and usually below the waist. Blood or protein in the urine again, joint pains, diarrhea or abdominal pain, and sometimes pain in the linings that can get inflamed, like around the heart or lungs. Now, compared to people who only have IgA in the kidneys, people who have IgA vasculitis throughout their body are usually young, less than 15. Usually the not kidney symptoms are more prominent. So it's usually like joint pains and rashes and diarrhea and abdominal pains more than the kidneys. If you did a biopsy of the skin or another part of the body, you would see the antibodies, the IgA antibodies there, just like you can see IgA antibodies in the kidney. When there's only a little bit or minor kidney involvement, the prognosis remains excellent. All right, now we're going to get to one of the most important sections, how the kidneys are doing, how the kidneys work, and what everyone, whether it's IgA nephropathy or any kidney disease, needs to follow. All right, true or false? For people living with IgA nephropathy, knowing their blood creatinine, eGFR, and urine protein can help monitor the aggressiveness and progression of their disease. True or false? All right, good. Once again, it looks like it's just about unanimous, and the correct answer is true. All right, so now, if you have a 25-year-old male bodybuilder who's 6'4" and 245 pounds, and an 85-year-old woman who's 5'1" and 95 pounds, each of these two people has a creatinine of 1.5, then they both have the same percent normal kidney function. What this means is, do these two people have the same GFR? True or false? These people have the same normal kidney function, the same percent normal kidney function, the same GFR. All right, once again, excellent. The correct answer is false. Now, the best thing to have in medicine is normal labs. But if you can't have normal labs, the next best thing is to have stable labs. I think a lot of times when I talk to people, they hope that every single one of their labs is going to go in the normal range, and they're all going to be green, and there's no longer going to be any yellow highlighted or red exclamation point labs. Well, I'm sorry, but that's not always the case. We have to have a conversation about expectations. After damage from an autoimmune kidney disease like IgA or anything else, a lot of times the kidney labs are not normal. But we do everything we can to try and keep them stable, to keep them in the same place as they've been for a long time. Now, the kidney's main job is to clean the blood, so what better place to start than the blood? Since the kidney's main job is to clean the blood, what we do is we measure toxin levels in the blood. The main toxin that we measure is this one called creatinine. When the creatinine goes up, it usually means that the blood is getting dirtier and the kidneys are getting weaker. That's not always true, as we're going to see in a minute. Now, this GFR is approximately the percent kidney function that is still functioning normally. GFR stands for estimated glomerular filtration rate. Now, the GFR is completely dependent on the creatinine, along with age and gender, which get plugged into the formula. But we take that blood creatinine, plug it into a formula, and estimate the GFR. As the creatinine goes up, the GFR goes down and vice versa. So I don't necessarily say to people, your creatinine went up and your GFR went down, because it's sort of implied. I don't say your creatinine went down and your GFR went up, because we know that. So you can talk about one or the other, and you know what the other one's doing. Now, the GFR does make it easier to compare the same creatinine number in different people, like we saw in the example of the true-false with the 25-year-old man and the 85-year-old woman, that they probably have very different GFRs. Based on the GFR more than the creatinine, that's when we talk about getting closer to kidney failure, transplant, or dialysis. Now, how else do we use the GFR? As the GFR decreases, a person progresses to the stage of kidney disease. Stage 1, 90 or higher GFR. Stage 2, 60 to 89. Stage 3 is usually divided up. A is 45 to 59, B is 30 to 44, and stage 4 is 15 to 29. These four are pretty much straightforward. Then it starts to get a little bit more confusing. So this is the current definition of stage 5. The GFR is less than 15, or if you started dialysis, or if you got a kidney transplant. So this is a little bit confusing because someone could get a kidney transplant at a GFR of 18, never have a GFR less than 15, and be called stage 5. It's also confusing because people who have a GFR less than 15 and are not on dialysis and don't have a kidney transplant are stage 5, but so are people that are on dialysis or have a kidney transplant. They're also stage 5. Now, you might hear something called stage 6. This is not really part of the stages of kidney disease, but the billing people made a 1, 2, 3, 4, 5, 6, so that's no longer ambiguous on GFR less than 15, not on dialysis, which is called 5, and anybody who's received a kidney transplant or started dialysis is called 6. Once again, 1 through 5 is what it really is. But since it's a little bit ambiguous, you might see that 6 every once in a while. In the United States, a person qualifies for kidney transplant or dialysis at a GFR of 20, but usually doesn't start until about 10 or less. It's in your best interest to put your name on the transplant list as soon as there's one GFR value of 20. You put your name on the list as soon as possible so that you get more time on the transplant list and you're further up the list by the time you get down to closer to 10. The GFR can rarely improve, such as when you're treating an acute injury, but in someone with kidney disease, chronic kidney disease, the GFR generally decreases over the years and decades, with good and bad days, ups and downs along the way. All right, now not every rise in the blood creatinine is bad. Most people have a blood creatinine and eGFR baseline range they stay within for a while, and that's our goal, to decrease the stress on the kidneys and have them stay within a range for a long time. Don't forget, the creatinine is a concentration or a fraction, number of creatinine molecules divided by the amount of water in your body. You probably remember from elementary school, you can make a fraction bigger by increasing the numerator or decreasing the denominator. But just because the concentration goes up doesn't mean that your kidneys are bad. Usually, when the concentration goes up, it's because the denominator got smaller. There's dehydration and less water in the body, so the creatinine concentration went up, even though the kidneys didn't get weaker. Now, there are some other times, like when we purposely give a medicine to somebody to tell the kidneys to do less work. We say, kidneys, do not work at your maximum capacity. Work less hard. Don't clean the blood as much as you can. By doing that, it lets the creatinine go up. But kidneys that don't work at their maximum capacity live longer than kidneys that are working at their maximum capacity. And that's why we do this. We didn't make the kidneys weaker. We told them not to work as hard so that they would live longer. All right, BUN. BUN is another toxin in the blood. I don't follow the BUN or worry much about it till it's over 100. A lot more things can influence the BUN than the creatinine. And you cannot calculate an eGFR in an adult anyways using the BUN. All right, true or false? In people living with IgA nephropathy, having a lot of protein in the urine usually makes the kidneys progress to kidney failure faster. True or false? All right, so this is going to be the first in a series of lectures and webinars on IgA. I guess next time I'll make the questions a little bit harder because that is also true. All right, your kidneys are like a pasta strainer. Your kidneys are like a pasta strainer. Your kidneys are like a pasta strainer. If you remember that, you understand a lot about the kidneys. So I tell people that like a pasta strainer, when you make pasta, the water goes through, but the pasta should stay in the strainer. If your pasta strainer gets really big holes, water goes through and the pasta ends up in the sink. If the kidney filter gets really big holes, Water goes through and other stuff ends up in the urine that shouldn't be there, like protein. In general, the more protein in the urine, the faster a person will progress to kidney failure. Now, I want to make one important point. Protein in the urine damages the kidney filter, causes more damage, causes more protein, causes more damage, like a vicious cycle. And that's what we're trying to break, that vicious cycle, as we're trying to protect the kidneys and get the protein lower, lower, lower. Blood in the urine does not have that same damage and that same vicious cycle. So if I see some blood in the urine, but the protein in the urine is normal, I'm much less worried. All right, now what labs do I follow to follow the protein in the urine and to check the urine kidney labs? Long story short, urine albumin to creatinine ratio. This is also sometimes called the urine microalbumin to creatinine ratio, but I'll point out, as someone reminded me to say tonight, there's no such thing as microalbumin. It's just the albumin on a very sensitive test. Now, this albumin to creatinine represents the holes in the filter, holes in the pasta strainer. We're going to talk about the other ways to measure protein in the urine, but those are not as specific to the holes in the pasta strainer, meaning damage to your kidney. Everybody has some, but we use the ratio, and the normal ratio is less than 30. You must use the ratio. You cannot use just the number. The reason you have to use the ratio is because using the ratio allows you to compare different urine samples, one time dehydrated and one time drinking a lot. Now, the other way to check the protein in the urine is either to use the urine protein or total protein to creatinine ratio or a 24-hour urine collection. I am not a fan of the 24-hour urine collection. I do not think it's more accurate than the random test, and I think that the albumin is more important than the protein. Now, everybody has some protein in the urine. The problem is that when you measure the protein to creatinine ratio, you measure the albumin to creatinine plus all the other proteins that might be there appropriately. After a vaccination and your antibodies get old, your kidneys pee out protein. If you have old vitamins, old hormones, your kidneys pee out protein, and that's appropriate. I don't really care as much about the appropriate proteins in the urine. I care about the albumin, which represents damage to the actual kidney filter. Now, again, you must use the ratio and not just the absolute number. And I do check these two things at the same time on the same urine sample, because if the two are really, really, really far apart, that means that there's an abnormal protein in the urine that's a problem. Now, don't forget, these are the urine concentrations. People often look at their blood concentrations, and that's not right. You have to look at the urine ones for the urine. All right, now we're going to get a little bit deeper and learn some terminology and definitions. Your body has 1 million microscopic filters in each kidney. So 2 million microscopic filters in your body, and they're called nephrons. The start of the nephron, which is what we're going to be talking about for the rest of the night, is where most of the filtering takes place. It's like a ball of blood vessels surrounded by the very beginning of the urinary tract. The glomerulus is the filtering part of the nephron. So every artery that goes into the kidney ends in a small ball of blood vessels called the glomerulus. Now, the nephron is made up of this filtering glomerulus, as well as the urine tubule that then can adjust all of the urine that the glomerulus filters. The word comes from the Latin glomus, meaning ball of yarn, and I think you can see how that looks like a ball of yarn. You will see the word glomerulus in glomerular filtration rate, which we saw, that GFR. Glomerulonephritis, as you probably know, IgA nephropathy is one type of glomerulonephritis. Glomerulonephritis leads to blood and protein in the urine from inflammation of these little filters, and that's glomerulonephritis. Glomerulosclerosis is permanent damage or scarring to this little filter. That's what causes damage to the filter, and that's what leads to the abnormal blood and protein in the urine and the abnormal labs, the scarring in the glomerulus. All right, so the blood vessel is only about as thick as a human hair. That's how tiny it is. And like we said, Blood comes in, goes into smaller and smaller little blood vessels until it ends in the glomerulus. Now, I think everybody knows what it looks like when you slice through a tomato and you see a tomato cut in half. Well, we're going to talk today about the glomerulus. So when you cut the glomerulus in half, we're going to think of these two pictures that we're going to use for the rest of the night. I will show you on the next slide what I mean. This is a picture of an actual kidney biopsy with a normal glomerulus. I put red blood cells in there so that you could see where all the blood goes in this tiny blood vessel, tiny glomerulus cut in half. On the right here is a cartoon. This is the glomerulus with all the little like blood vessel loops, and that's the way the blood leaves. This is the start of the urine. The name of this is called Bowman's capsule, which you might have heard. But this is the glomerulus. This is the start of the urine. This is what we're going to be talking about for the rest of the night. This is the literal filter. This is the literal pasta strainer. So the wall of that blood vessel, the wall of these tiny little loops, is where the pasta strainer lets some things through and not others. So the blood comes in and the blood goes out. Let's take a closer look of a normal kidney function. So once again, these walls are the filters, the pasta strainers. And just like a pasta strainer, things go through. What goes through the filter? Water, BUN, creatinine, sodium, potassium, chloride, acid, bicarbonate, calcium, magnesium, phosphorus, anything that fits through the holes in the pasta strainer, the holes in the filter will go through. Now, don't worry. When the good stuff goes through and goes in the urine, it goes into the urine tubules. And later on in the nephron, the urine tubules can reabsorb anything that it wants to keep. And that's probably the end that we're going to talk about the tubules, and the rest is going to be focused on the glomerulus for the rest of the night. Now, interesting fact, the rate at which things get filtered through the filter is literally called the glomerular filtration rate. And that's what we're estimating when we use that formula. So as you see, the proteins come in, the blood cells come in, and all these BUN, creatinine, sodium, potassium, chloride, magnesium, phosphorus, those all come in. They all fill up the little bitty loops of the blood vessels. And then when it leaves, all the blood leaves, all the protein leaves, but a lot of the little molecules are no longer in the blood, leaving the glomerulus. Let's take a closer look. So normally, water and these small molecules go right through the filter. They go right through the wall of the blood vessel and the urinary space cell wall. So this filter allows all those little things to go through. With normal filtration in a normal kidney, the red blood cells and the proteins do not go through the filter. They're too big to fit through. So all of the blood and all of the protein and just a little bit of the small molecules leave the glomerulus. But most of those little molecules leave and go out in the urine and go through the tubule. All right, true or false? A kidney ultrasound can diagnose IgA nephropathy. So once again, everybody is doing well, and the correct answer is false. All right, just about everybody with abnormal blood or urine tests will get a kidney ultrasound, but the kidney ultrasound looks for other causes of high blood creatinine, like abnormal kidney anatomy, and it looks for other causes of blood and protein in the urine, such as kidney stones or tumors. All right, now we're going to talk about how does IgA nephropathy happen. We are going to transition from the normal kidney to what happens in IgA nephropathy. All right, true or false? In IgA nephropathy, a person's own immune system makes antibodies that attack the abnormal antibodies. True or false? True or false? True or false? So the answer is true. All right, so now this is kind of like another one of the top things to take home. We usually say that there's 4 steps in the way IgA happens, and you have to get all 4 steps. Step number 1, a person who has IgA nephropathy must make the abnormal IgA antibody. Usually when they're trying to fight a virus or bacteria, this abnormal IgA antibody is called undergalactosylated, which you might have also heard. Now, the immune system makes its own antibodies against the abnormal IgA antibodies. Step 3, the antibodies stick together and make clumps. And step 4, those clumps get stuck in the glomerulus filter, in the pasta strainer, and cause the symptoms of leaky protein in blood in the urine. Let's take a closer look. So in step number 1, something, usually a virus or bacteria, makes a person make antibodies. Some of those IgA antibodies are abnormal. Now, the person's born with the ability to make these bad antibodies, but they have to be exposed to the correct virus or bacteria. For example, some people may get an IgA flare-up with COVID, but they may not get an IgA flare-up when they get the flu, say like 2 weeks later. Some of the antibodies are abnormal, and because these antibodies are not correctly made, they're undergalactosylated, they look wrong to the person's immune system, like they need to be attacked. So since they need to be attacked, what happens? The person's own immune system comes across these antibodies while traveling through the blood, and the person's own immune system makes antibodies that then attack those antibodies. The antibodies stick together and make a clump. More parts of the immune system, those blue little spikes, which are called complement, join in, and this clump is called an immune complex. These immune complexes travel through the blood just like all your blood does. Eventually, when they get to the kidney and the glomerulus filter, they get stuck. And since they got stuck in between and in the filter, they cause inflammation. It breaks the filter. It allows things to leak out of the filter that should not be leaking out of the filter. And things end up down there in the urine that should not be there, like blood and protein. This inflammation can cause permanent kidney damage and might eventually cause kidney failure. All right, so the simplest way to look at IgA or any autoimmune disease is that the abnormal antibody is then encountered by the immune system, and antibodies are made against the abnormal antibody, which leads to immune complexes that travel through the blood. All right, we're going to come back to our cartoon here, and now instead of talking about the normal kidney, we're going to talk about what happens in IgA nephropathy. So once again, the lining of the blood vessel and the urinary cells is the filter. This is the pasta strainer. Usually it lets through little things. Usually it does not let through big things like protein and blood. So what happened? All of these antibody immune complexes are coming in with the red blood cells, with the protein, with the small molecules. They all go down into the little capillary loops. And as you can see, the immune complexes are getting stuck. Now, instead of all of the blood and protein leaving the glomerulus, only a small amount of the blood and protein is leaving the glomerulus. Let's take a closer look. All right, so once again, in someone with IgA nephropathy, the normal stuff still happens. Water still goes through the filter. Small molecules still go through the filter. So the BUN, creatinine, sodium, potassium, acid, bicarbonate, chloride, magnesium, phosphorus, they all go through still. But because of the damage to the filter, bigger things get through too. protein goes through, blood goes through, and down here in the urine, you have blood and protein with all your small molecules, and less of it is leaving the glomerulus. Now, there was a question about trying.
Chevalier, there's a question. Is there research to teach your immune system antibodies not to attack the abnormal IgA antibodies?
So the short answer is people are working on that. The interesting thing is that autoimmune diseases are actually very similar to kidney transplants or any organ transplant for that matter. And there is work being done to try to teach the immune system what it should and should not attack. So transplant research doctors are trying to teach the immune system to not attack a transplant kidney. And autoimmune research doctors are trying to teach the body not to attack certain other things. The protein does not get attacked itself. That's correct. What happens is that these antibody complexes are traveling through the blood. These immune complexes are formed in the bloodstream, and they travel through every cell in the body. When they get to the kidney filter, they get stuck. In people who have IgA vasculitis, some of those IgA antibodies can get stuck in other small blood vessels in the body. The protein leaks through the filter. It does not get attacked. Now, there is a little bit more damage than I'm sort of letting on to. Once the immune complexes get stuck in the kidney, that leads to inflammation. That inflammation is a little bit more complicated than just immune complexes cause inflammation. That's probably best described in the treatment lecture in the future. But the point is that inflammation is what causes the big holes in the filter and the stuff to leak out. All right, so I just want to make one more super point to reinforce this. In someone with IgA nephropathy, the immune complexes cause damage to the filter. So not only does the normal filtering happen, but inappropriate filtering happens as well, where things leak when they shouldn't, like the blood and the protein. And yes, the more damage there is to the filter, the more protein and blood in the urine. And as we're going to see as we go on, there's a few ways that we tell how severe or how aggressive someone's IgA nephropathy is. Number one is the blood creatinine or GFR. You can use either. Number two is the amount of protein in the urine. So yes, the size of the filter holes, size of the holes in the filter, or the damage to the filter. And then number three is going to be the biopsy, which we're going to talk about in a second. All right, so how bad is the protein in the urine? Well, the two charts on the right show the answer. Now, the upper right, or the top chart on the right, is pretty much the data that people had for years, if not decades, where they said that anyone who was less than 1,000 milligrams in the urine was fine. Now, for years, people didn't recommend getting a kidney biopsy or using medicines to suppress the immune system or doing much more than supportive care for anyone who had 1,000 milligrams or less of protein in the urine. Now, the thing that I was always concerned about is that this study only lasted about 12 to 15 years. But many people with IgA are diagnosed in their teens and 20s. They could live for another 50, 60, 70 or more years. And the people in these studies had worse kidney function at the end of like 12 and 15 years. Shouldn't we do more than just watch them? Well, in 2024, just earlier this year, the bottom chart came out. And it showed that the goal really should be less than 500 milligrams. Now, all those little asterisks next to the number mean statistically significant, as if you did the experiment 100 times, more than 95% of the time, you'd get the same outcome. And it's probably true that getting lower, like less than 300, might be an optimal goal. The problem is that even if we use every therapy we have today, there are many people that just can't get below 300 milligrams, and we do the best we can. All right. The only true path to diagnosis is via a kidney biopsy. True or false? An IgA nephropathy kidney biopsy with 70% scarring is better than an IgA nephropathy kidney biopsy with 10% scarring. True or false? All right, correct answer is false. So how much of my kidney does a biopsy actually take out? Well, here's a picture from a kidney biopsy that I did. On the left, you'll see the needle, which is very, very skinny, but quite long. On the right, you will see an up-close picture of actual pieces of a kidney biopsy next to a quarter for size. The biopsy samples are less wide than dental floss and less than an inch long. All right, while blood or protein in the urine or a rise in creatinine suggests IgA, only the biopsy can diagnose it. The biopsy tells you the cause of the kidney disease. It also gives the diagnosis, aggressiveness, and can guide treatment. It's possible to get infection, bleeding, or a biopsy doesn't give the diagnosis, but it's a very safe procedure in the year 2024. The person rests after the biopsy and should do no heavy lifting or exercising for a week to get a good scab on the kidney. Pre-biopsy labs are checked. No Advil, Aleve, ibuprofen, Motrin, or aspirin for a week before the biopsy. So how does this help us? Well, we have something called the MEST-C score. This was made from the Oxford classification, where a bunch of doctors got together, looked at all sorts of IgA nephropathy kidney biopsies, and came up with a way to say how aggressive the biopsy was. Each one of the letters in MESTC gets a number next to it, 0 or a number greater than 0. The M stands for mesangial hypercellularity, E is endocapillary, S is segmental sclerosis, T is a lot of scarring, and C is crescents, the most aggressive type. Now, I don't think you need to know or memorize what each of the letters stand for, but to understand that the numbers after the letters is how we decide how aggressive the IgA is and how we treat it. Now, the MEST score started around 2009, and the C was added to the MEST score around 2016. So if a person had a biopsy done before 2009, they might not have a MEST score in the report of their biopsy. If a pathologist was able to look at the original glass slides for the biopsy, it is possible to give a MEST-C score today. It's maybe possible to give a MEST-C score based on the description, the written report, but having the original slides, it could definitely be done. All right, now, every number in the MEST-C score that is not a 0 increases the risk of a person having kidney failure. So in general, you add up the numbers, like 1 plus 0 plus 1 plus 0 plus 1, and that gives you a total score. The higher the number, the more aggressive the disease. So in general, it goes 0 to 7. Now, there's a few letters which are even more specific and mean more. So the E and the C often mean that the immune system is actively attacking the kidneys, and that the IgA is attacking the kidneys now and would probably respond well to medicines that suppress the immune system. The MS and T usually represent scarring or dead kidney that we can't fix. So some people think that when the E and C are 0 and the M, S, and T are at their highest, that could be the worst score because it's all scarring and nothing to respond to treatment. Now, one study did find that the S, T, and C were more predictive of giving the risk of kidney failure. And you can use this for both adults and for kids. All right, now just like the protein in the urine, we can use the MEST-C score to say the chance of kidney failure. As you might have guessed, the higher the number when you add up the MEST-T score, the higher the chance of kidney failure. The lower the number, the better prognosis. Now, in this particular study, most of the people had less than a gram of protein, which back in the day was thought to be no big deal. And the people in the first two groups had close to a normal GFR, which means the people in this group had very mild disease, which is why their numbers are lower than the proteinuria slide before. So to me, this study says that even in people with fairly normal labs, a kidney biopsy helps guide the management and helps determine prognosis, which is why I do favor a kidney biopsy, even when there's less than 1,000 milligrams of protein. All right, to repeat or to not repeat a kidney biopsy. Whether it's a first biopsy or a repeat biopsy, the biopsy can help with diagnosis, aggressiveness, and management. Now, if the abnormal labs continue or worsen despite treatment, a doctor might want to repeat the kidney biopsy. If the E and the C are positive, that usually means the immune system's attacking the kidneys. If the E and C are negative, that usually means that that the immune system is not attacking the kidneys. And you could always have a new diagnosis. The point is that treating the immune system actively attacking your kidneys is different than treating old immune system attacks or just scarring. Now, have you ever wondered what a kidney biopsy looked like under the microscope? Well, I'll show you. So we send the tissue on a kidney biopsy to 3 different microscopes. The first microscope is the light microscope. This is the one that you're familiar with in high school, where you look through the top and you have a glass slide sort of on the stage and you turn the little heads. That's where we get the MEST C-score, the M, the E, the S, the T, the C. It's all on the light microscope picture. We then send it for the immunofluorescence microscope. We take all sorts of different antibodies, IgA, IgG, IgM. We take different kinds of complement, which I mentioned before, and we look and see which ones are attacking the kidneys. In IgA nephropathy, it's the IgA antibodies which glow the brightest. Now, the biggest, closest up picture we do is the electron microscope. So as you can see, this one little circle on the light microscope is this one circle here on the electron microscope. It's really, really, really blown up. This is the space that's sort of in between 2 of those little blood vessel loops, and these actually represent some of the deposits here. Let's see. Would there be a case where you suspect IgA nephropathy, but you don't recommend a biopsy, and why? The short answer is yes. When there's very little protein in the urine, like maybe 100 milligrams, where I would not use any medicines to suppress the immune system, and I would just use supportive care, then I would not necessarily do a biopsy if it wouldn't change the management. All right, are you a good IgA nephropathy detective? True or false? A person with celiac disease is more likely to get IgA nephropathy than a person without celiac disease. True or false? So this one's a little bit more split, but the correct answer is true. True or false? A vaccine can trigger an IgA nephropathy flare-up. True or false? So once again, the answer is true. After the COVID vaccine, especially the mRNA COVID vaccine, we had many people with IgA nephropathy that ended up having a flare-up. Usually an infection causes a cold or diarrhea. So it's usually an infection of the respiratory tract or the GI tract that causes IgA. However, some other medical conditions are also associated with IgA. If a person has these conditions, they need to be controlled. Inflammatory bowel disease, autoimmune disease, gluten allergy, infections, and cancers can all stimulate the body to make IgA antibodies and cause IgA nephropathy. All right, at our hospital, we're trying to create pop-ups in the medical record system when a person has blood protein or abnormal kidney blood tests in order to see if they can get them referred. In some countries, they do a lot of screening. In a lot of Asian countries, they screen school-aged children. In other countries that have mandatory military service, they screen with the urine and they will treat them if needed. This is probably cost effective, and catching people early decreases the number of people that end up with kidney failure. College physicals might also be an opportunity. All right, my infamous summary slide. IgA nephropathy is caused by the body producing abnormal antibodies that form complexes and get stuck in the glomerulus. IgA nephropathy symptoms: foamy urine, blood in the urine, swelling, high blood pressure. The only way to diagnose it is with a biopsy, but it also tells you about aggressiveness and guides treatment. Blood creatinine or GFR, urine protein to creatinine ratio also help monitor and manage. All right, I will get to the questions, and then I will take the two that I see in the question. Question that you should ask your nephrologist. What is my blood creatinine and eGFR, if you don't already know it? What is the protein level in my urine? What is my MEST-C score? When should I come back for a follow-up visit? And what symptoms would make me call for a sooner appointment? All right, my daughter had HSP, now 10, still dealing with the protein in the urine. How would you say she has IgA nephropathy and what for life? So the HSP question, hopefully everybody can see the question, but it's basically about someone who did have IgA vasculitis as a child and still has blood and protein in the urine. It's the same thing as anybody with IgA nephropathy, where we're trying to decrease the protein in the urine. Look for any triggers, try to avoid the triggers if possible, and then do things that support the kidneys, like blood pressure control, cholesterol, sugar, avoid obesity, don't smoke, etc. I do recommend vaccines to everyone. The only vaccine that I do not recommend is the mRNA COVID vaccine, because we've had more than 100 people that flared up after that. Outside of the mRNA COVID vaccine, I have not seen enough significant flare-ups to stop recommending it. What percentage of children with HSP end up with IgA for life? That's a tough question to answer. A lot of people with IgA vasculitis end up having a complete resolution with complete normalization of their labs. So the only people that I really see as an adult are people that don't resolve. The people that don't resolve, we focus on decreasing the stress on their kidneys, like I just mentioned, even if the IgA is not actively attacking their kidneys. So the webinar, that's coming up, so I'll get to that in a second. So inflammation from unhealthy eating and lifestyle, we don't know for sure, but we suspect that if you eat healthy and exercise, you're less likely to have aggressive disease. We're trying to prove that. All right, a question for the audience. Which of the following is true? You can answer in the chat. A, blood and protein in the urine confirms the diagnosis of IgA nephropathy. B, a MEST-C score of M0E1 S0 T0 C1 generally means the immune system is actively attacking the kidneys. C, a kidney transplant protects people with IgA nephropathy from making any more abnormal antibodies. D, a kidney biopsy removes about 10% of a person's kidneys. E, although anyone can have IgA nephropathy, women are more likely than men to have IgA nephropathy. Go ahead and vote in the chat. Pregnancy and IgA was another suggestion that we were going to have as a future talk. Your eGFR is not guaranteed to permanently go down with a pregnancy. The correct answer is B. All right, let's go on to the next question. Which of the following is least likely to be seen in IgA nephropathy? High blood pressure, blood in the urine, extremely high cholesterol, protein in the urine, a rise in creatinine in the blood. Go ahead and vote in the chat. The correct answer is C. Everyone is correct. All right. Last of our multiple choice questions. Which of the following is true? Having a blood creatinine of 3 is better than a creatinine of 2. Having a MES score of 6 is better than a MES score of 3. Having an albumin creatinine ratio of 1500 is better than a protein ratio of 500. A PC ratio of 2000 is better than a PC ratio of 1000. A GFR of 50 is better than a GFR of 40. Go ahead and vote. Does eGFR get calculated for children and are children staged? So the GFR that we did, you have to be at least 18, but it probably works if you're done with puberty. Children are staged in a similar GFR, stage 1, 2, 3, 4, 5. I am not a pediatric nephrologist, so those are just general answers. Gluten sensitivity causes your body to make lots of different antibodies, but since the antibodies are in the GI tract, the IgA is secreted into the GI tract. If a person was born with the ability to make bad IgA antibodies, the IgA is secreted, the abnormal IgA is secreted into the GI tract to fight the gluten. The correct answer is E. Everybody is correct. The table you shared earlier referred to proteinuria. Can you compare? So the proteinuria was the protein in the urine at the time of diagnosis. So they probably did a 24-hour urine collection. They did something a little bit more advanced in some of the studies called a time averaged protein in the urine. But for simplification, it's probably a protein to creatinine ratio is the closest, usually to the time of diagnosis, but they did follow the people over 12 to 15 years. The risks of a kidney biopsy we mentioned briefly: infection, bleeding, lack of a good diagnosis, and I would not biopsy if it was not going to change the diagnosis, like if things were only mild. Now, this is probably the most important question, so everybody go ahead and answer. Like I said, this was meant to be the first in a series of webinars about IgA nephropathy. We are planning to have another one, hopefully in several months, the second in a series. So if you would like to vote and give a suggestion about what you'd like the next topic to be, please go ahead and vote. We'll be able to see it in the chat later. All right, I guess we'll take a few more votes here. So diet was going to come into the treatment, but the short answer is the only thing that's been proven beyond a shadow of a doubt is sodium. So a moderate sodium diet, or what would be considered like a low sodium diet, is about 2,000 to 2,300 milligrams a day. That's our suggestion for people who have kidney disease in general, including IgA nephropathy. You do not need to go to 1,000 milligrams and be ultra restrictive. That might actually be not enough for you. Protein is highly debated. I usually say that you can estimate the amount of protein that you need based on your body weight in kilograms. So if you're not very active, you probably get about 0.8 grams of protein per kilogram of body weight, not pound, kilogram of body weight. And if you're very active, exercising multiple times a week, you probably could go up to 1.1 or 1.2 grams of protein per kilogram body weight. You probably shouldn't go above that because you're not going to be able to use it, and it's just going to be excreted out in the kidneys. Other than that, we don't have any definite recommendations that have been proved in a randomized controlled trial. All right, the last question I was going to ask is, for people that live in the greater New York City area, we have had open houses for people who have certain conditions. So we've had a PKD patients open house, and people have come. It's been little education, but mostly it's been for patients and people with IgA to talk amongst themselves and share stories about what they've experienced, tips that they've had, things like that. So I was wondering if we had an IgA nephropathy open house, maybe in the spring, if people would attend. Okay, so I'm excited to see that there's a lot of yeses. Does low protein help? Not necessarily. So like I was explaining, we don't have any randomized controlled trials to definitely make sure it helps. If you get too low, it might actually hurt you. So unless you're somebody who's very, very old and would probably die on dialysis, I don't personally recommend a very low protein diet. I recommend based on your body weight, like I was saying earlier. All right. I think I covered all of the questions. So I would like to say a few thank yous. Thank you to Bonnie Schneider from the IgA Nephropathy Foundation and to David Feldman from the National Kidney Foundation. They both helped me with input and assistance and feedback on this lecture and helped me get it to the final form. And to Dr. Salvatore, who did give me the kidney biopsy pictures. And I do want to thank our sponsor, without whose help this whole program would not be possible. If there's no other final questions, we might, so we hope that this is being recorded. We're hopefully going to be able to put it on our website at some point. I don't want to make you a promise I can't keep, but that is something that we're hoping to do in the future. So there's no way to tell 100% for sure if you're dehydrated, but there are a lot of things that give you suggestions. So when the BUN is really, really high compared to the creatinine, like the ratio is very high, that might be a suggestion. You're right, if on the CBC, if the hemoglobin is much higher than the baseline, then yes. Certain other things like albumin, calcium being very concentrated, all of those things might suggest dehydration. I think the most suggestive thing would be on the urine. So if your urine is very concentrated, that usually means that you're dehydrated. All right, people with only one kidney can also get IgA nephropathy. People with IgA in one kidney, it's a little more challenging to do a kidney biopsy, but it is possible, and the treatment would be the same. Apheresis does not work well for IgA nephropathy as far as we know. In the little bit where it's been tried, it's not so easy to get the IgA out because it's kind of a small molecule. Apheresis does better with larger molecules like IgM. And a lot of the IgA, don't forget, is secreted into the lining of the respiratory tract and the GI tract. So you don't actually get a chance to take that out of the blood. You should be okay to donate with IgA nephropathy, but that's a question for the blood people. You should declare that when you when you donate, but the amount of IgA should die of old age in the blood before it causes serious damage. It is impossible, at least right now, to know if you make the bad IgA. We are hoping to be able to test for that in the future. There's no test to know if you have the genetic capabilities. The two kidneys do act in parallel. So when we do a random biopsy of one piece of one kidney, it represents both kidneys in their entirety. Blood travels evenly throughout both kidneys, and whatever's in your bloodstream, like those immune complexes, will affect both kidneys equally throughout. There are definitely cases of cutting out gluten and seeing remission from IgA. The medicines to treat IgA is going to be in the treatment talk, which sounds like it might be one of the next ones in the series. A person can test positive for IgA at any point in their life. We've even had senior citizens that have been diagnosed with IgA, but by far the most common time to be diagnosed is in your teens or your 20s. All right, thank you for everybody for all the nice comments in the chat. I hope that you all enjoyed tonight, and I look forward to seeing all of you and more at the next IgA lecture and webinar. Christina, would you like to wrap it up?
Yes, good evening, everyone, and thank you so much, Dr. Chevalier. Thank you for that amazing presentation. And we will communicate about the future talks, so do look out for them. And again, thank you all for attending tonight.
And the last question that Shonda asked, is it more common to have both IgA and vasculitis? It's actually more common to have just IgA nephropathy. Vasculitis is a smaller proportion of the people who have IgA. Good night, everybody.